Now that you're familiar with the anatomy on chest x-rays, let's look at some pathologies or some changes in the structures you identified. Let's go through some cases. This case is pretty subtle. Here's a patient that we've had a prior chest x-ray from. The image on the left was taken 10 years prior. The image on the right is the current chest x-ray that is showing something of concern. Can you see any structural changes from a prior image? Perhaps a line that is normally there that's now obscured? What is this line indicated in pink? It is the paratracheal stripe. It is where the right lung pleura abuts up against the trachea, forming a line. The lower portion is the azygous arch. On the current image in the patient, do you see the paratracheal stripe? It is thickened. This could indicate that there is a mass in this region. The patient should undergo a CT to better visualize this area. The upper right is a chest CT from the patient we just saw the chest x-rays from. On the lower left in green is a different patient but a normal image of this same region for comparison. Note that the normal reference has contrast and our patient does not. First, let's identify the structures that we know. What is this anterior circular structure? It's the ascending aorta. Now this circular structure, it's the superior vena cava. Now this would be the descending aorta with some calcification. What about these two? The arrow is pointing to the azygous vein, and the circle is indicating the esophagus that is open with air at this moment. It can also be seen in the reference image as a solid circle. The merged two dark circles just anterior to that is the carina, where the right and left main bronchi are starting to branch off. So now we know some of the normal anatomy. What do you see that's problematic in our patient's CT? The arrow is pointing to a mass. There's a mass just behind the superior vena cava and ascending aorta. It was determined that the mass was enlarged lymph nodes, and further testing indicated it was metastatic. Therefore, the patient was diagnosed with small cell lung cancer. Although the mass is clearly seen in the CT, the loss of the paratracheal stripe was the first indication of a problem in this region, warranting further investigation. The patient image is on the right. A normal image from a patient is on the left for comparison. What changes do you see with the patient? First, the mediastinum is pretty wide. The contours on the left are normal, if a little exaggerated. And on the right side, what structure is this? This is the ascending aorta. In this case, there's actually nothing wrong. It is called aortic unfolding, which is a normal occurrence with age. We can see these two images, a normal contour in a younger person on the left, the patient we just saw on the right with an elongated aorta, making it more tortuous and curvy. This will significantly increase the calcification deposition. This case is included so that you're aware of some other, yet normal causes for mediastinal widening. Here is additional imaging showing even more severe aortic unfolding in a 99-year-old. On the right, we see a chest x-ray from a 16-year-old patient presenting with shortness of breath and pain with inspiration. What do you see? Is there anything that you see that might be concerning? Here is the same radiograph shifted over to the left. It's taken at inspiration as any good PA view would be. Now the chest x-ray was repeated at the point of expiration for comparison. What do you see now? Can you see the subtle dark lines? These lines are actually enhanced with expiration. What do dark lines on an x-ray indicate? Dark lines indicate air. Let's identify these dark lines. On the left inspiration image, we see air between the pericardium and pleura, as well as the azygous esophageal recess. On the right, expiration enhances these findings. The diagnosis for this patient is spontaneous pneumomediastinum. It's a good example of air in the azygous esophageal recess, which normally is a white stripe, not dark with air. Here's a little information from the case discussion regarding this occurrence in young persons with excessive or severe coughing. There is something wrong here. What do you see? Can you identify the location of the problem? Is it a problem with the mediastinum? Is it a lung problem? Is the problem the right side or left side or both? Is the problem superior or inferior? This lung also has an issue, a different issue. This is a completely different patient. What do you see with this patient? Here are the images from the two different patients to compare and contrast their conditions. What similarities do you see? It's in the right upper lobe that the issues are located. Are the issues the same or different? Is one more advanced than the other, or do they have completely different etiologies? Let's go through patient 1's findings. We see a hyperdense area in the right upper lobe region that extends above the clavicle. The right hemidiaphragm is notably elevated. The heart and mediastinum is shifted over rightward. We can see this nice curve of a pleural line. This is the right middle lobe filling upward into the right upper lobe space. So the diagnosis of this patient is right upper lobe collapse. This is atelectasis on a large scale, where atelectasis is collapse of lung tissue, but in this case, it is an entire lobe. In patient number 2, we also see an issue with the right upper lobe. There is opacity, but it's less dense than the last patient. This line is the horizontal fissure, and it's clearly seen in its normal position, as is the diaphragm. Within the opacity are dark lines called air bronchograms. That shows that there is air in these airways, but something is in the space around it, so there's a greater contrast highlighting these bronchioles. So this patient has right upper lobe consolidation, where the lobe is still intact. It just has something denser than air in the interstitial areas and air spaces, such as infection or blood. This can be diagnosed as lobar pneumonia if there are also signs of infection. Note that the term consolidation is a radiologic sign referencing such an opacity as we see here. To determine the actual cause of consolidation and therefore to make a diagnosis, further testing and evaluation must be made. Here's a summary of 3 common issues found with the lungs on chest x-rays. You're familiar with the pneumothorax. There are different types of pneumothoraxes, with the little diagram showing an open version. The close would be from a ruptured bleb, and the dangerous tension pneumothorax is a subtype of collapsed pneumothorax, where the escaping air goes out of the lungs but is still trapped within the thorax. So with each breath, it has nowhere else to go, so the lung gets compressed. For atelectasis, it can arise from an airway being blocked by a mucus plug or tumor, so the distal area is not being ventilated, causing that area to collapse, and then the diaphragm elevates and tissues shift over to that side. Another cause for atelectasis is compression of a lung region. Consolidation is something occupying a region of the lung. This can be localized to one area, as in the example previously seen in patient number 2, or more distributed and widely spread, such as pulmonary edema. For this condition, the affected region has more diffuse opacity and often retains air bronchogram markings. So, what's going on with this patient? First, you should note the very black hemithorax. This is due to air in the cavity and absence of lung tissue. As the lung is compressed here, so this is a pneumothorax. However, let's also see the additional findings. The trachea is shifted away, as is the heart moved to the contralateral side, and the diaphragm on that side is depressed. So this is no ordinary pneumothorax, it's a tension pneumothorax, and this is a critical finding that is in a medical emergency.